Hello, everybody, and welcome to our webinar today entitled Psychedelic Therapy for Major Depression. My name is Shannon Woodruff. I'm the marketing manager here at Clinilabs, and I will be your moderator today. Today's webinar is being presented by Clinilabs Drug Development Corporation, and before I introduce today's speakers, I'd like to just cover a few housekeeping items. Today's webinar is being recorded. We will be able to share a link with you after the event is complete, and we welcome you to revisit the content at any time and share it with your colleagues. We also invite your comments, questions, and responses to our poll questions on the polls tab. Please take a moment to identify the interaction panel on the right side of your screen. If you think of a question at any point during the presentation, please add it there, and we will hold it for our Q&A portion at the end of the event. Our presenters today include Dr. Alex Belser, Chief Clinical Officer at Cybin. Dr. Belser is a licensed psychologist, clinical supervisor, and psychedelic researcher at Yale in psilocybin clinical trials. He has over 20 years' experience in psychedelic research. Also with us today is Dr. Amir Inamdar, Chief Medical Officer at Cybin. Dr. Inamdar is a qualified psychiatrist and pharmaceutical physician with over 20 years of clinical and drug development experience. Without further ado, I'd like to introduce our first speaker, Dr. Alex Belser. Dr. Belser, take it away.
Thank you, Shannon, for that introduction. It's lovely to be here with you all and to get to share with you a little bit about something I am incredibly passionate about, which is psychedelic medicine and psychedelic-assisted psychotherapy to help people with unmet needs. We're focusing today on depression. And in some ways, the story of depression is the story of, especially our failures to treat it well, to figure out good ways to help people who are suffering from depression is a story of the history of mental health. And I'm hoping that in the next 15 minutes or so, I'll be able to share with you a little bit about the quick tour, the quick history of how psychedelic medicine might be useful in treating people with major depressive disorder. We'll take a look at some of the best evidence, randomized controlled trials, and we'll also talk a little bit about our treatment at Cybin. We're beginning a clinical trial looking to recruit individuals who have major depressive disorder to be treated with CYB003, which is our deuterated analog of psilocybin, which is the active ingredient in magic mushrooms. But I'll show you there's some excellent evidence published in top-tier journals about this. And then finally, we'll talk a little bit about the treatment itself before handing it off to Dr. Amir Inamdar, our Chief Medical Officer. We'll talk a little bit about the therapy, the human aspect. How do we support people before, during, and after these sessions with the medicine to help them prepare to experience what they might, different states of consciousness they might experience on psychedelic medicine, and also how to keep gains, as we see in multiple trials, keep gains that they have in terms of their depressive symptomatology. So I'm going to go ahead and begin sharing my slides here with you all. And we'll start with some of the cautionary statements just to make sure that you know that we are talking about a clinical trial to investigate whether or not this may be useful. I'm going to try to provide a rationale for why we're even doing this in the first place. And I think there's some really excellent evidence. But let's start with where we're at today. You've heard of psychedelics. Obviously, and you may have heard that there's been a psychedelic renaissance, a resurgence. It's come back into fashion after many decades of being off of the research map. Here we have an article in Nature talking about how psychedelics take flight. The number of registered clinical trials is exploding geometrically. We have in publications, similarly, a geometric expansion of the number of articles that are coming out in peer-reviewed literature about psychedelic medicines for the treatment of a variety of mental health concerns, including depression. And so you see here a little bit of a blip in the 60s and 70s with psychedelic medicine. This is the sort of first wave of clinical trials and methods, and then a period of quiet for many decades until really the early 2000s. when we see just a huge explosion of research, and that's being led at some of the top tier medical centers and universities around the world. It started really at places like Johns Hopkins and UCLA, and my team at New York University and at Yale, Imperial College, and a few other wonderful places. And it's now expanded not just from a handful of universities with centers for psychedelic research, but to well over 100 universities around the globe. And it's gone from a $0 industry to large and small pharmaceutical companies trying to get treatments over the line with the regulators, with the FDA, conducting phase 1, 2, and 3 trials to determine if there's strong enough evidence to merit prescribing these medications in supportive ways. And we see that through the FDA, the Food and Drug Administration, granting 3 designations of what they call BTD, or breakthrough therapy designations. So they've named psilocybin in 2 trials for depression and treatment-resistant depression, and MDMA as for PTSD as BTDs, breakthrough therapies, putting them on a regulatory fast track. And so there's a huge amount of excitement. Which is, frankly, a delight for me. We started work at NYU in 2006, and I was involved a little bit before that. And you're sort of out in the woods for many years, but now psychedelic medicine is sort of coming back into the mainstream. There has been a concern that psychedelics are dangerous, but in a recent review by David Nutt and colleagues that was published in The Lancet, a reputable journal, they took a look at the harms caused by drugs just in the community, not even in supportive, clinics. And it's what you'd expect. Alcohol and heroin and crack cocaine cause the most harm to self and to others, whereas mushrooms down at the very bottom are seen to be, of all illicit substances, the one that cause the least harm, almost no harm to others. And the times that they are harmful is because they're not in a supportive setting or a context. We see similarly in a meta-analysis of safety that when you actually do this work, psychedelic-assisted psychotherapy, in a supportive condition, in a university or industry trial, what we see in this meta-analysis, which is already out of date, it's 10 years old, that there's been hundreds of psilocybin administrations, and it has consistently demonstrated that we can do this safely, that people who take this medicine tolerate it well, not only acutely, but in the long run. And although it induces profound changes in people's mood, how they're feeling, their perceptions, their thought, their story of themselves, they largely experience this as non-threatening and even pleasurable. We've had, up until recently, no serious adverse events, and those serious adverse events have been attributed during the course of trials to the placebo condition, actually. And all acute drug reactions were managed in the room, because people are with their treatment provider through interpersonal support. There's no follow-up reveals that there's no issues of drug abuse. There's no issues of persisting perceptual disorders. There's no long-term psychosis or other long-term impairments of functioning. So now for the good news, which is that depression is a bear, but potentially psychedelic medicine may be used to treat it. And we see that with the FDA's approval of esketamine, a psychedelic drug through Janssen Pharmaceuticals for the treatment of depression and suicidality. But there's good evidence here, and we're focusing today on serotonergic hallucinogens, meaning drugs like psilocybin and our compound CYB003, which is a deuterated analog of psilocybin, which will have very similar effects, I think, to psilocybin. What we see, and this is in my research at New York University, our team, led by Steve Ross and others, we did a trial with people with cancer looking at their depression and anxiety. And I'm going to focus on the left in the middle pink bar graph. You see that after we give them supportive psychotherapy and a moderate dose of psilocybin, we have an over 80% response rate in terms of improvement in depression scores. 80% of our participants in this trial of 29 people respond, as compared to the crossover group which is given an active placebo drug. They have less than 18%. I think it's 14% response. So it's a huge distinction in the active group versus placebo. And on the right, you can see that time course over time. There's a nice differentiation between people who get psilocybin and people who don't. This finding is mirrored in our sister trial led by Dr. Charlie Grobe. This is at UCLA, and Alicia Danforth. Nice discrimination. People who get a low to moderate dose of psilocybin in advanced stage cancer get less depressed, and they stay less depressed over a 6-month follow-up. Again, similarly replicated and co-published with Johns Hopkins University. These are all measures of depression, the GRID-HAMD, the Beck, and the HADS depression. But at both low and high dose, nice response curves, really promising. And this is what these studies really build evidence for the subsequent trials. And I'm sure as mental health practitioners, you've all worked with patients and worked with colleagues, and you know that the existing treatments are in some ways disappointing. We have a whole host of pharmacotherapies that are approved by the regulators for the treatment of depression, but the effect sizes, the amount of benefit, statistically speaking, is rather small. So here's something published in the New England Journal of Medicine. It's a review of all the existing effect sizes, which is a measure of the improvement in the standard deviation for your standard list of conventional antidepressant medication. And you'll see in here for each drug, there's a little white circle and a little black circle. The black circle is including the pharmaceutical companies' unpublished manuscripts, the studies that they ran that they decided to put in the file drawer to prevent from being seen in the peer-reviewed literature, but they were required to submit them to the regulators. And what you see here is that almost none of these drugs across the board exceed in FBA-based effect sizes 0.2 effect size. So it's just a very small benefit. Now, some people do benefit from this, but as we see in the STARDY trial, oftentimes it takes multiple courses of medication. Why people are excited about psilocybin is that we see effect sizes that are of large magnitude effect. Here's a recent meta-analysis. The effect sizes are highlighted on the right. We have effect sizes of somewhere between 0.8 to 1.5. This is almost an order of magnitude bigger than you're seeing in some of these trials. And in a recent trial at Imperial College, Robin Carhart Harris and others put together a nice study looking at benefit. And we just see, benefit across the board. Again, this is a similar trial with Dr. Davis looking at depression scores at the top. In a delayed treatment, people don't get better, but in the immediate treatment at week 5 and at week 8 follow-up, there's a really substantial large effect size in this Hopkins study. We have a head-to-head of psilocybin versus escitalopram, and in nearly every measure, except unfortunately the primary one at primary endpoint, there's a nice statistical differentiation where psilocybin outperforms escitalopram, the leading antidepressant medication for the treatment of depression. This is the hardest trial in the books, and we see that psilocybin therapy performs really well. And then in a very large trial with over 100 subjects, we see Compass Pathways data and the treatment for treatment-resistant depression. These are people who have not responded to 2 or more pharmacotherapies. The blue line is the psilocybin group versus the gray line is the comparator, the 1 milligram very, very low dose control. And we see a nice differentiation and really at least twice the response rate in the blue line here versus controls. So people are pretty excited about the prospect. It remains to be seen whether or not this will these benefits with psilocybin might help in large studies for major depressive disorder. But I want to just turn a little bit to this trial. we have a FDA IND and IRB approval. We're recruiting for a trial to work with CYB, named after Cybin 003, which is a deuterated psilocybin analog. And my colleague and friend, Dr. Amir Inamdar, will discuss this in more depth. But just a little preview, CYB3 is an analog of psilocybin, and it's deuterated, meaning it replaces one or more hydrogen atoms with deuterium, a more stable isotope that reduces some of the pharmacokinetic variability. And what we're seeing in our preclinical models is that CYB3 is going to have psychedelic effects and therefore we believe benefits, clinical efficacy benefits. But as compared to psilocybin, there's some difficulties with psilocybin. It's an 8-hour day in the clinic. It's very long, very expensive, not necessarily accessible because of clinic costs. You have to wait for an hour for it to take effect. So there's a slow onset of action. There's a lot of variability between patients. So some of the patients I've seen in our trials have a huge experience on the same dosage as other people have barely a threshold experience. There's a lot of metabolic variability in the plasma levels, in part because psilocybin is converted to psilocin in the gut. It's a prodrug, actually. So there's additional variability for dosing precision. And with CYB3, our team has worked really hard to reduce some of this variability so that we're going to have more precise, safer dosing. We're going to have a faster onset. So instead of waiting an hour or an hour and a half for the effect to come on, people will have effects, we believe, potentially within minutes. We also see a shorter total duration of action. We may even have clinic times, which will reduce costs significantly. And we're going to have a therapeutic benefit at much lower doses. So the patient has to take less dose of the medicine into the body, potentially better tolerability, potentially less nausea, for example. And lastly, I'll just close in the last few minutes by sharing a little bit about, the way that this study is unlike other studies, which is that it's not just about the drug and the pharmacokinetics. It's not just SSRIs that suppress symptoms, but we're really combining the psychedelic medicine with a psychedelic-assisted psychotherapy. And this is the standard in all of these models. And in fact, the FDA is requiring us to have a licensed psychotherapist in the room at all times. And if you refer people to this study, they'll actually be working with 2 facilitators at all times. So they get a really intensive therapy and treatment that was designed for depression. And what my colleague, Dr. Bill Brennan, and I have done is recently published, if you're interested, a review of all the different models. There's so many models of psychedelic therapy. And we reviewed 17 of them. We looked at each one and looked at the evidence for them, the evidence-based theory that supports a model of change for the psychedelic treatment. This is used in all sorts of different trials. And we assess them in various ways and try to distill with them, and then also in conversation with senior trainers and teachers, a new model, the model we call Embark. And now Embark is a transdiagnostic, transdrug model. That means that we are adapting Embark, which is a psychedelic-assisted therapy with this medicine for the treatment of major depression in this study in New Jersey. But we are also using it potentially for other diagnoses in the future, and as a transdrug model, so it can be used for different psychedelics. The kernel that you just should know is that we designed the human aspect of this, the human supportive psychotherapy aspect of this, to have 6 clinical domains that build from the existing psychedelic experience. When you give people a psychedelic in a clinical trial, they have a variety of things that happen for them. And so Embark is an acronym, EMBARK, and each of those 6 domains addresses and supports people before, during, and after to have the types of things that we do see in our trials at NYU and Yale when people are given psilocybin. So they have existential and spiritual experiences. And we actually think that these experiences may be one of the reasons that we see clinical benefit. It's consistently tied to depression benefit. The M in Embark stands for mindfulness. We encourage a practice of focusing awareness in the present moment and on inner experience. The B domain of Embark is the body. We see with psychedelics that people have strong body experiences, and we know that the body Somatics can be a site of healing. And that's where Bessel van der Kolk's work on the body keeps the score. We want to address that directly in this integrative, coherent therapy model. We want to take a look at evidence-based treatments through the affective and cognitive, the A domain of Embark. We want to support people with identifying and welcoming and experiencing those feelings that are sometimes hard to feel. Emotional states more fully, to have both catharsis and integration. And lastly, these two last domains are really important. The R domain in Embark is relational. This is the human aspect, that we have a relationship of trust in the room with the facilitators, but also when people are given psychedelic medicine, they have experiences of even visions of meeting their loved ones, their deceased parents or godparents, grandparents. They have experiences of a relational rapprochement with ex-boyfriends and with their children. The work is deeply relational. It's not just necessarily purely a biomedical framing, especially from the human experience, the subjective experience. And lastly, keeping momentum. It's all fine and good if people benefit for a day or a few weeks, but what about benefiting for months? How do we have a relapse prevention piece? So we want to provide supportive psychotherapy sessions after the medicine sessions to promote integration and translation of benefit. I'll also just say that we're attentive to the ethical concerns in the space, and we have 4 ethical cornerstones. The work is, and we try and strive to provide trauma-informed care, culturally competent care, and ethically rigorous care within a collective care context. And so we have 4 cornerstones of care, 6 clinical domains, and that's our model of psychedelic-assisted psychotherapy in this trial. So I'd like to thank you for your time and turn it back to Dr. Amir Inamdar. Thank you.
Hello and welcome to this webinar on psychedelic therapy for major depressive disorder. I am Dr. Amir Inamdar. I am a psychiatrist and I work at Cybin as the Chief Medical Officer. And I'm going to speak to you today about an ongoing study with CYB003, which is our proprietary psilocybin analog. And this study is being conducted in major depressive disorder. What I'm going to do is briefly cover 2 aspects of the study. I will talk to you a bit about what CYB3 is, and then I will give you an overview of the study design. So the psychedelic compound psilocybin is a natural product. It's produced by numerous species of the psilocybin mushrooms. Chemically, it's a tryptamine derivative which is cleaved in the body to produce psilocin, which is the active metabolite. And psilocin is active at a variety of serotonergic receptors in the body. The most important of these is the 5-HT2A receptor. Psilocin peaks in the blood after oral absorption in about an hour or so, and the effects last for about 6 hours or so. CYB003 is our proprietary synthetic deuterated analogs of psilocybin. We've seen that psilocybin has been effective in a range of real-world studies. For millennia, it has been shown efficacious in ritualistic practice, and all of these data support the utility of CYB3 in mental health disorders. So this figure visualizes the concept that oral administration of CYB3, which is shown by the blue curve, would likely result in a fast onset of psychedelic effect, which basically means peak concentrations could be reached twice as fast compared with psilocybin. There is expected to be a shorter duration of exposure compared to psilocybin, which is expected to translate in a shorter psychedelic experience in the clinic. It basically means less downtime in the clinic. Reduced variability with CYB3, which is seen by the smaller error bars, basically means dosing is quite predictable. And finally, an improved brain to plasma ratio should translate into lower doses needed for therapeutic effects and therefore better tolerability. So what does this favorable PK profile translate into? Well, low PK variability means that there is more consistent and predictable dosing, which also means improved safety. A fast onset of action means the patient spends less time anticipating the psychedelic effects, so they have less anticipatory anxiety. A shorter duration of effect means less downtime of the patient in the clinic, less resources required in terms of clinic and staff time. And rapid redistribution to the brain means that the drug spends less amount of time in the periphery, in the GI tract. Therefore, side effects which are GI related, such as nausea and vomiting, are less. It also means smaller doses are required to exert the same effect for equivalent doses of psilocybin, and that would be expected to translate into less adverse effects. It also makes CYB3 a more commercially viable product as a psychedelic medicine. So, what does the study look like? Our study is a randomized double blind placebo controlled study. We are conducting this in participants with major depressive disorder. And as with most first time in human kind of studies, the prime aim of the study is to determine safety and tolerability of rising doses which are given orally of CYB3. In addition, we'll also be looking at pharmacokinetics of ascending oral doses. We'll be looking at the psychedelic effects, and we will also be looking at efficacy in treating symptoms of depression in otherwise healthy participants with major depressive disorder. Um, in this study, we will enroll approximately 32 participants suffering from major depressive disorder. Now, these will be spread across 6 cohorts, and these are cohorts of unequal size and will range from 4 to 8 participants each, with sentinel dosing in each cohort. Now, as you will see, the earlier cohorts are smaller in size, and these are primarily designed to understand initial PK and safety before we go into larger cohorts of 8 participants each, which will fully assess the efficacy. Cohorts 5 and 6 are again smaller cohorts, and these cohorts may be combined if we think it's necessary to do so. In this study, each participant will receive either 2 doses of CYB3 or 1 dose of CYB3 and 1 dose of placebo. And I'll show you on the next slide how this will happen in the cohort structure. These doses will be given orally, and these will be given in an oral solution, which will be in the form of a citric drink like tank. And while we conduct the study, we will be escalating the doses gradually, which will only be done after satisfactory review of available safety, PK, and tolerability data. These will all be reviewed at the safety review committee, which will occur both within the cohort and between each cohort. So now looking at how each cohort looks like. So when participants come into the study, we screen them. If they are found suitable, then they are randomized to receive either CYB3 or placebo. After randomization, they are expected to undergo a series of preparatory psychotherapy sessions. These are 3 in number, and Dr. Belser will speak a bit more about what these preparatory sessions and psychotherapy sessions look like. And following the prep sessions, the patients will receive either CYB3 or placebo at day 1. The session on day 1, the medicine session, is expected to last about 4 to 6 hours. We'll obviously find this out as we get more PK from each cohort in the study. But essentially, after the session is over, the participant stays in the clinic and they are discharged next day when everything is found to be okay with them. Over the next 3 or so weeks, the participants will undergo a series of sessions of integrative psychotherapy using the Embark framework, and they will come back into the clinic at the end of 3 weeks to receive the second administration on day 2. Now, compared to day 1, where participants could receive either placebo or CYB3, on day 22, all participants will receive an active dose of the medication. After the second administration, the sequence of visits and assessments is the same as the first part of the study in the first 3 weeks. There will be a safety visit at week 6, which will also be, in a way, the end of the study visit, which will be followed by a safety follow-up about 2 weeks after this visit at week 6. Now, this cohort design allows us to do a number of things. It allows us to look at whether a single administration of the study drug is effective. So you look at those participants who receive study drug at day 1 and assess them at week 3, and we find out whether a single dose is effective or not. When they receive a second administration of the study drug, we also are able to understand whether there is an incremental benefit of a second administration of the study drug CYB3. We are also able to make a within subject comparison of people who receive placebo at baseline and CYB3 at day 22. So we're able to compare placebo and active within the same participant. And owing to the optional 12-week follow-up, we are also able to evaluate the durability of these effects up to 12 weeks. So who are the patients we are looking for in terms of enrolling in this trial? Now, these are participants with major depressive disorder. These will be diagnosed based on DSM-5. The diagnosis will be confirmed using the mini neuropsychological interview. And in terms of severity of depression, these patients are expected to be at least moderately depressed. Now, this is assessed using the Montgomery-Åsberg Depression Rating Scale, where we require a minimum score of 21 for these participants to be eligible for this trial. This means they can also be severely depressed, but if they are severely depressed, we require these participants to not have any psychotic features accompanying their MDD diagnosis. Now, MDD should be the principal and the primary diagnosis, which basically means it's the condition that has precipitated a referral or a contact with the healthcare system. And it should also be the primary diagnosis, which basically means it's a diagnosis that best accounts for the clinical and the presenting features of these patients. We will allow secondary diagnoses, so diagnoses of anxiety disorders or PTSD, acute stress disorder, or OCD as comorbid diagnoses, but these cannot be the primary diagnoses. Other diagnoses such as eating disorders, for example, or personality disorder, or any neurological conditions like dementia, for example, they will not be permitted in the study. These participants are also expected to be on stable treatment with antidepressants. Now, what stable means is in the past month, there has not been any significant change to the dosage of their antidepressant medication. They have not started new drugs or stopped a drug. And a significant change is defined as no more than 50% change in the dose of the antidepressant medication. These antidepressants will include selective serotonergic reuptake inhibitors or SNRIs. They're both allowed. We'll also allow bupropion or trazodone, but there are certain restrictions in terms of antidepressant medication. So we will not allow any patients who are on monoamine oxidase inhibitors, any tricyclics, mirtazapine, antipsychotics, or any mood stabilizers. These patients are also expected to be suboptimally responding to their ongoing antidepressant medication. So basically, these are not patients who are having a good response. You do not want to stop their medication, and you do not want them to switch to the clinical trial. But these are patients who you have started on an antidepressant medication, but they're not really responding well. And typically in clinical practice, what you would do is to maybe switch them to another antidepressant or add another treatment to their ongoing treatment. And these would be the ideal patients for this clinical trial. Now, one thing to bear in mind is these patients cannot be treatment-resistant patients. And this is defined in the protocol as failure to respond to at least 2 different antidepressant medications taken for an adequate duration and an adequate period of at an adequate dose. And the adequate dose obviously is whatever stated on the package insert or the label. We will also not include patients who are currently suicidal. So we'll be using the Columbia Suicide Severity Rating Scale to assess suicidality. And the threshold on that is a score of 4 on the ideation subscale of the Columbia. In addition, any prior history of a suicide attempt would mean that these patients are not eligible to participate in the studies. Um, these are not habitual users of psychedelics, and we provided some guidance in terms of thresholds regarding frequency of use in the past 10 years or the past 6 months. These are also patients who do not have a substance use disorder in the past year. They are also not regularly using excessive amount of alcohol, and excessive is defined in terms of a 21 units of alcohol threshold. Now, one thing we realize is that many participants may test positive for cannabinoids, especially given that marijuana is legal in many states. So, we can include participants who test positive for cannabinoids at screening, but these participants must agree to abstain from any marijuana use during the study, and during the screening period, this is the opportunity for them to abstain from marijuana such that they test negative on the day before dosing. So, day -1 and day 20. They must be negative for any cannabinoids. Any participant who continues to test positive is not an ideal candidate for this study. Again, these are MDD patients who are otherwise healthy. We are specifically calling out an exclusion of hypertension or hypothyroidism. Hypertension because all psychedelics have effect on the cardiovascular system. They result in transient increases, self-limiting increases in blood pressure or heart rate. So we don't want already people who are suffering from uncontrolled hypertension. And in our non-clinical studies in animals, we did see some effects on the thyroid. So we do want to exclude people who may be suffering from hypothyroidism. So we've also defined some criteria where we will ensure that the study stops in case something is going wrong. So if we find one or more cases of Hy's law, which basically is an indicator of liver injury, drug-induced liver injury, and is defined as a increase in the ALT of more than 3 times the upper limit of normal, or serum bilirubin, which is more than 1.5 times the upper limit of normal. So if this is found to be associated with CYB3, then we would want to stop further dosing in the study. Any serious adverse events which are found related to CYB3, or any severe drug related adverse effects which are noticed in the same cohort. Intolerable anxiety, fear, distress, which requires a rescue medication. Again, that becomes a criterion that we use to stop dosing in that patient and in that cohort. We will also not continue to dose if we see that significant psychedelic effects are already being observed at a certain dose level, because with psilocybin, effects plateau at a certain dose level, and beyond that there are no beneficial effects, only side effects if the dose is escalated. So if we see that there are significant psychedelic effects in at least 75% of the participants in 2 consecutive cohorts, and we've defined what significant psychedelic effect mean, then we will stop escalating the dose. Then there are some criteria related to cardiovascular safety based on heart rate, based on QT prolongation, hypertension, which will mean that we don't go beyond that dose level. And finally, if there is suicidality seen in any participant, in 2 or more receiving CYB3 and is related to to patients receiving CYB3, then we will stop dosing in that cohort and dose escalation. We may stop individual patients from receiving the study drug. So if somebody has severe nausea or vomiting which cannot be controlled with supportive measures, then they may not receive subsequent doses of CYB3. Similarly, if they have excessive anxiety or panic, they may not again receive any further doses of CYB3. And if they on day one of dosing or after day one of dosing, if they continue to have any perceptual disturbances, then they will not receive a second dose of CYB3. In addition, we've got some criteria related to the levels of the drug in the blood, so the PK stopping criteria, and these are based on what we saw in the dog at the zero point 0.5 milligram per kilogram dose. So, what happens in each different scenario? Now, if cohort stopping criteria are met, then we obviously stop dosing in that cohort, but the data gets reviewed by the safety review committee, which anyways reviews the data during the cohort and between the cohorts, and it may take a decision to either continue the study, to reduce the dose, or to stop altogether. If an individual participant meets a stopping criteria, then we could withdraw that participant from the study and they may not receive any further doses. And if we meet PK stopping criteria, then it means we do not go beyond that dose level. So, as I mentioned, we are including participants who are taking stable antidepressant medications, but we would not allow any other prescription medication other than their ongoing antidepressants. There could be some acetaminophen which can be prescribed for pain. Participants may also receive sedatives or hypnotics for sleep. Now, point of clarification that these sedatives or hypnotics should only be received for sleep. They should not be prescribed for example, an anxiety condition. If the primary purpose of the prescription is anxiety, then these patients will be excluded. But participants can receive sedatives or hypnotics occasionally for sleep, and that's defined as no more than 3 times a week. We also need to take care that before they come for a visit and about 12 hours before any assessment, they do not receive any sedatives or hypnotics. We'll allow contraceptives, we'll allow hormone replacement therapies. We'll allow some rescue medication. For example, if a participant has high blood pressure during the session and an antihypertensive is administered, that will be allowed. If somebody becomes paranoid or extremely anxious and they require, for example, a benzodiazepine or an antipsychotic, that will also be recorded in the case record form. Now, we have also put in place a strategy that takes into account the potential adverse effects that could be seen with CYB3 and how to mitigate them. Psychedelic effects, now, I think that's the big question. What is considered to be a beneficial effect and what is considered to be an adverse effect? With psychedelics like CYB3, there will be effects which indicate a mystical experience. There may be formal thought disorder, there may be dissolution of the ego, there may be perceptual disturbances like hallucinations, mood, mood changes, anxiety, etc. Most of these are part of the picture of effects that you see with psychedelics, but they can become excessive and they may cause distress to an extent that requires intervention. One way to address these and to mitigate the risk is to prepare the participants for what they can expect during a psychedelic journey. But there are medications that can be administered, such as a benzodiazepine or an antipsychotic, which are quite effective in terminating psychedelic effects that are untoward. There could be other physical symptoms like nausea, vomiting, some cardiovascular symptoms like increases in heart rate. Changes in temperature are quite common with psychedelics. All that is required is supportive management, a warm blanket, for example, and in the extreme cases, changes in blood pressure, maybe an antihypertensive if that is indicated. There are some other AEs or adverse effects of special interest. Suicidality, for example, which is a fundamental feature of the illness, but this is something that we'll be monitoring very closely. We'll also be looking at other adverse effects which are persistent, like HPPD or hallucinogen persisting perceptual disorder. That's a mouthful. But this can again be managed with uh, adequate preparation. Things like potential suicidal ideation can be managed as much as possible with managing expectations of participants, having frequent check-ins with patients post-dose, and also once their participation in the study is complete, handing them over to their primary care physician in a smooth manner will ensure that effects such as treatment emergent suicidality, for example, is not as common in this study. Right. So we've taken a number of steps to ensure that the participants in this study are safe. The things like we're starting at a very low dose for our first cohort. These are doses that we typically call as sub-psychedelic, which means that we don't really expect any significant effects at these doses. In addition, we are making sure that there are at least two qualified therapists or facilitators who will supervise the dosing sessions, and they are there in the room with the patient at all times to make sure that if there is anything untoward that were to happen, then the necessary support may be provided. We are also employing sentinel dosing in each cohort and in each subcohort. What that basically means is that we are not going to dose everybody at the same time. For every cohort, we will start the dosing with only two participants. We will review the data from these two participants and make sure that nothing untoward is seen in those safety data. And only when we are convinced, we will then dose the rest of the cohort, or rest of the participants in that cohort. We've also established a safety review committee, or an SRC, which is comprised of experts, physicians, as well as experts within the psychedelic field. And this safety review committee will be responsible for reviewing the data as we go along. They will perform a comprehensive review within each cohort, and they will also be looking at the data between two cohorts of patients before we select doses for every subsequent cohort. And finally, we've put in place, as I mentioned earlier, stopping criteria that are specific to individual subjects as well as cohorts, to ensure that we stop dosing and stop dose escalation as such in case any untoward effect arises in the study. So that was a brief overview of the study. I hope that you found that useful, and thank you for your attention.
Thank you, Dr. Belser and Dr. Inamdar. That was certainly a very interesting and thought-provoking topic. First question: are there studies comparing CYB3 versus psilocybin?
Not yet. This is our first in-human study, and so we're required, in part, to make sure to proceed slowly with escalating doses to make sure that it's safe for people. But that's something we might want to consider in the future, taking a look at the relative merits and benefits of one of the compounds over the other. Yeah. Amir, do you have anything to add?
Well, just to add that not in humans, at least. We've done studies in animals, but not in humans yet.
Okay, next question from Jennifer Gordon. If subject is having psychedelic effects, are there ways that safety assessments or scales can be conducted / captured?
So usually for the scales, there are scales that measure subjective effects with psychedelics, like the hallucinogen rating scale, the mystical experience questionnaire, etc. And these are usually administered at the end of the day. So they're not giving people's assessments right in the middle of their experience, usually. So those data can be captured based upon recent recollection. And that's been industry sort of academic standards for a while. Yeah. We'll be taking contemporaneous PK data. So we'll have some of the biomedical data, and we'll also be assessing for just a simple question, which is reduces patient burden, we just basically said, like, how intense is the experience for you right now of the drug that you're experiencing? It's just a simple, 1 to 100 scale. So it's not we're not asking people to fill out long questionnaires or anything during their experience.
Can you talk more about dosing cohort 1 sentinel subjects, cohort 2 sentinel subjects, cohort 1 n equals 8, rather than cohort 1 sentinel, cohort 1 n equals 8?
Yeah, instead of trying to figure that sequence out, I'll just kind of go through how the cohorts are designed. So cohorts 1 and 2 are actually small cohorts. They are not n equal to 8, they are n equal to 4. And the reason they are n equal to 4 is because these are lower doses of CYB3, where potentially the psychedelic effects would be limited. So we don't really want as many patients at lower doses in cohorts 1 and 2. The sentinel structure would be in cohort 1, we dose 2 participants, 2 sentinels. We review the data and then dose the remaining 2. The same thing in cohort 2. 2 participants will be sentinel patients. And once we review those data, we dose the remaining 2 participants. In cohorts 3 and 4, we have 8 participants each. And in those cohorts, we'll employ a similar strategy where we dose 2 sentinel patients. And once we review the safety data, we are satisfied with it, we will dose the remaining 6 subjects in those cohorts.
Any risks of compounds becoming monopolized by pharmaceutical companies, leading to prohibition of the medicine in its natural form? If so, is something being done or can be done to prevent this?
It's a very complex set of questions. I can address it, Amir, unless you would like to start.
No, go on.
So one of the natural compounds, I mean, first of all, there's this issue of plant medicine and natural compounds. For example, actual plants or mushrooms growing in the earth, which still generates these medicines. It's in part how we know that psychedelics might be useful, because we've learned through many wisdom traditions, including the Mazatec shamaness Maria Sabina and other extant lineages of people using psychedelics in various ways. In part, we benefit from that wisdom and knowledge. These drugs are not, first of all, there's some organizations that are trying to take natural compound and extract them and make them meet the standards for medicine that groups like the FDA or the MHRA might require. So they would extract actually from a whole plant. We see this in the cannabis world, where you can have synthetic cannabis or, growing from a whole plant. And that may happen here in the future. Many of the psychedelic compounds are not monopolizable in the sense that they are, the recipes are published online in groups, in books like PCAL and TCAL. So that there's not an intellectual property ownership leverage over them. They exist out in the world. I think we're probably going to see that continue to be the case going forward. Yeah.
Can participants continue Suboxone?
The simple answer is no, because Suboxone will be prescribed to them for opioid use disorder, and we won't really be allowing patients with the substance use disorder in the study. There was a question around concomitant medications earlier. I think it was about whether patients can be on esketamine and ketamine who are partial responders or suboptimal responders. But it's a complex one in the sense that we need patients who are already on an antidepressant, an SSRI or an SNRI, to participate in the study. Esketamine is not an approved antidepressant. It's also typically a drug that is given to people who suffer from treatment-resistant depression, and we are not allowing people with treatment-resistant depression in this study. So from that point of view, again, that's not allowed. The population that we are looking for is patients who have been started on an antidepressant treatment and they are not responding well. So they've been given an adequate trial, which means given for an adequate duration and an adequate dose, but they're not really responding well. And typically in clinical practice, you would be moving them to either another antidepressant or maybe adding something like therapy. Those are the patients you want in this study who are currently on an existing antidepressant.
Okay. Looks like we have two questions that came in. One question, is there a list of the exclusionary criteria for participation on the website? I believe that there is, correct? Okay, last question. Why are mood stabilizers not allowed?
Well, mood stabilizers would typically be given to people suffering from bipolar disorder. If you have a patient with depression who suffers from bipolar disorder, then that's bipolar depression, and we are not including patients with bipolar depression in the study.
Okay. So it looks like now we're done with Q&A. I would just like to thank everybody for their time today and remind them, if you are interested in collaborating with Cybin and Clinilabs on this very important trial, please feel free to contact Diane at Cybin.com. Once again, thank you to everyone who joined today. Thank you, Dr. Belser and Dr. Inamdar, for your time and expertise. And if you have any additional questions, just feel free to contact us. Thank you.
Thank you, everyone.
Thank you all.
Great
Thank you,
day.
Shannon.
Bye-bye.
Thank you, Amir. Bye-bye.